This is story of a 55 years old lady who underwent CMV in 1997, mitral valve replacement in 2008, had a CVA with left hemiparesis along with seizure disorder with lesions in the right MCA territory, right temporal intracranial hemorrhage in 2013. So she has got all the ready mix for a ready recurrent stroke slash bleed. So she presented with complaints of shortness of breath, 1 week duration. ECG showed atrial fibrillation, fast ventricular response, and this was his mean PG across the prosthetic valve. So cool, very cool. Max PG is 14, mean PG is 6. All looks hunky dory. Is everybody comfortable? Whoever is the everybody here, nobody. So you're comfortable? Okay, if you're comfortable, I'll show you some more pictures. This is what the picture shows. Are you comfortable with this? You are? Okay. So we'll come back to this picture again. This is another view of the same, which is more akin 4-chamber. If you're happy with that, we'll go further ahead. This is his tricuspid regurgitation, and if you look at the tricuspid regurgitation, this regurgitation is gross and the pulmonary artery pressures are reasonably high because this is 37 across the tricuspid regurgitation itself only. IVC is hugely dilated and it is kind of fixed if you look at it in respiratory motion across, hardly any motion. So his 37 would be about 50 odd. Comfortable? We do a TE now, and this is what it is. When you look at this, you are finding that there is only one leaflet moving. Now, how do you explain this? That the mean PG is 4, stuck valve, pulmonary artery hypertension. Still, you are convinced that it is a stuck valve. Are you or are you not? If it is a stuck valve, how are you going to explain it? Now, this is something which we need more evaluation on. So, as all of us are doing, we are all very fond of 3D. Again, proves beyond reasonable doubt that it is stuck valve. Look at this half moon opening, half moon closed. Fluoroscopy, gold standard, and here it is. Now there is no confusion. There was no confusion earlier also, but this is no confusion. So what are we looking at? Why are we getting those pressure gradients which are so low? This was the question. So there is something known as a silent. Now, I'll show you one picture where you are expected to see both the leaflets moving, which is on the right side. And if you look at this, there are two leaflets which are bobbing up and down. Here you see only one, which is this person in question. And in both the views that I saw, there was only one leaflet which was moving. So this is how you are picking up cues to pick up high index of suspicion. This high index of suspicion leads to a diagnosis which is called as the silent Doppler pressure half time. And this silent Doppler pressure half time is because this patient, along with stuck valve, had a very poor left ventricle. When the left ventricle is poor, the left ventricular end diastolic pressure is going to go up. When left ventricular end diastolic pressure goes up, the LA to LVDP difference is so short that the pressure gradients come down. This is what is known as a silent Doppler pressure prosthetic valve thrombosis. So this is something which I just wanted to show. I wish more of students were here because people who are here already know about most of the things, but I wish more people were here. Okay, one more prosthetic valve and then I can pick up other topics. 22 years old lady underwent aortic valve replacement of 17 millimeters St. Jude's for severe AS, mitral valve replacement of 27 millimeters of Medtronic, tricuspid valve replacement of 27 millimeters ATS for severe TR. 11 months later, she presented in OPD with complaints of palpitation and shortness of breath for lasting since 15 days prior to admission. Are you comfortable with this data? Actually, I was hunting for the surgeon. when I saw this, I was desperate to find out who the surgeon is. Because at the age of 22 years, I would not want to give three metallic valves. If three metallic valves, certainly not on the tricuspid valve. If on the aortic valve, certainly not a 17. This is a pediatric size. So there are so many things which were amiss here, but despite that, you can't debate with three types of people. You can't debate with God, your wife, or the surgeon. This I don't know how many of you have experienced this or not, but the two of them here have to be careful about the two, because the third one doesn't exist for them. Okay. So this is what we found. ECG is fairly non-specific for what we have to find out. But if you look at this, this is what it is. This shows functioning. Mitral seems to be very good, because if you see, both the leaflets are bobbing up and down. This is, again, both the leaflets are bobbing up and down. This is where it is. You have a normally functioning PHV at mitral with, again, a mean PG of 4. Aortic, across aortic is 12. So what are we dealing with? Now we are dealing with a tricuspid valve which seems to be stuck. Now it's difficult to identify things in the tricuspid valve. RV is something which is difficult. People have started realizing the importance of it only very recently. But if you look at it, the mean PG across tricuspid valve is 11. You should not get a gradient across tricuspid valve. If you have to take a catheter data across tricuspid valve, the catheter difference of RA to RV should be 0. Here the mean PG is 11 and the max PG is 17. So certainly we are looking at thrombosis in the tricuspid valve. Now here we are doing a TEE, all the TE. This valve looks good. Tricuspid is, the mitral is good. As far as tricuspid is concerned, here you can't see it, very shaggy images. All the same, there seems to be some evidence that one little thing moves here, and okay, so this is more appropriately seen. This is one leaflet which is seen here, the one is stuck. This also is moving very, very sluggishly. So we had to go back to our gold standard, that is tricuspid across tricuspid valve is high gradients. Fluoroscopy, the most definitive, is 3. This is on the right side. If you look at it, this is more dramatic. If you look at this, this is very sluggishly moving. This is the tricuspid valve. This is almost stuck in semi-open situation, and this is the one which is mitral, which moves well. Now, the patient was thrombolized with streptokinase. Again, I was very unhappy, because streptokinase is something which is not my first choice for thrombolysis of tricuspid valve. I would have been happier using the TPA, but doesn't matter. And then post thrombolysis is this. Now you can see it better, because the shadowing is lesser because of the leaflets moving, and this is what is the tricuspid valve. So here we are looking at a very complicated case of triple valve replacement and tricuspid valve replacement. Now, the guidelines are fairly clear these days that if you have a right-sided valve which is stuck, thrombolysis is a reasonable choice. If it is a left-sided valve which is stuck, then the first choice to be given is surgery, redo surgery. Because the chances of thrombolysis and going into the brain or to the end organs like kidney, not the kidneys, but splenic infarcts, the renal infarcts, or the cerebral infarcts are very high. So in left-sided valves, change the valve, right-sided thrombolyze, but with appropriate situation. So this is what we are, and the pun I wanted to make, I just hope there is no surgeon around. In any case, there are no non-invasive cardiologists. Where will the surgeons come? So there is. Don't allow the surgeons to make all the decisions. Okay, any comments on that? Then I'll otherwise go on something else. Three images, and then we'll call it. Yes, sir. So,
It was a very good case, sir. Actually, even I had similar cases, but I didn't think in terms of low output or increased LVDP. That is, whenever we get a low gradient, we are very happy because that is, we simply reassure the patient that you're better. You can we need not worry. That is after surgery. We don't want to make the patient again a patient. This
Correct.
is
So
good.
actually, there is something known as a bias. Post-surgical bias to underreport problems is always there.
Yes, sir. So
This
this is
is
very eye opener, sir.
this is okay. Since we have more people here, we can have more discussion.
Yes, sir.
Simple, simple. What is this?
Aortic regurgitation.
Lovely. Mild, moderate, severe.
It's mild, sir.
Mild. Very good.
Mild to moderate.
Mild to moderate. Mild. Mild. Okay. So this is an aortic regurgitation. We'll. So she doesn't have EKG. I'll give you something better than EKG. Okay. Here it is. So somebody wanted to know whether it is systole or diastole or systole or diastole. No diastole, now systole. What is this? Whoever has heard of a continuous AR? So spot on, but let me just put it to the crowd here. This is AR continuous. So, sir, why do you say that this is AR? AR occurs in which phase of
Aortic regurgitation during
diastole?
yes, sir.
So this is systole and diastole both.
Yes, sir.
How come? How can AR be there in systole?
No idea, sir.
So she is spot on. She's got it before anybody else could.
No, it's not coming. No, it's coming.
So if you look at this, this patient has had left ventricular assist device. When you have a left ventricular assist device, there is a inflow of blood which is there, outflow from the left ventricle. They put in a device. It's a big cannula which draws blood through a motor and pushes it back into aorta. Now, LV to the motor to aorta, and this is a continuous process. This is not phasic. It is not systole diastolic. It is continuous. So, if there is a aortic valve which is leaking, this is how it will behave.
Oh, okay.
And I'll show you some pictures. This is a continuous. Here, they have changed the setting, so the aortic valve is moving in and out. And if you look at this, again, this is, but you should adjust the left ventricular assist device in a manner that max to max about 3 or 4 beats later the valve should open. Most of the times it should stay closed. That is how you should adjust it. But this is the place which will let the cat out of the bag. This is the place, if you look at this, this is the cannula or the inlet, outlet from where the blood is being drawn. Can you see this? This is a huge big thing at the apex. This is the suction thing. Okay, any comments on this?
Yeah,
Otherwise, go further.
I was going to say that yes, not only that you see the AR is, when you see AR is continuous, and if it is truly moderate in nature, you have to let the surgeons know about it, because as long as it's mild, it can be tolerated. But these patients are extremely sick. They are in cardiogenic shock. That's why LVAD is there. So it's very important to quantify the aortic regurgitation, and particularly right after LVAD is done, so that you can give the surgeon that feedback. Yes, yeah.
Normally you have to close the valve.
There should not be any.
Okay, So this was a red herring from one of our ex technicians, very sharp girl she is. And she says, sir, I don't think that this is something normal. And there is an international fraud called the preventive health check. I don't know how many of you. Preventive health check or the executive health check, where they'll do, for a man, they'll do every test from top to bottom, including pregnancy test. And then they'll come out with some nonsense that you have got zinc, which is high, and selenium, which is less. So, this is in the preventive health check. The 63 years old lady comes, asymptomatic, routine echo, and this is what the final report was. And but this girl was very uncomfortable. She says, "No, Dr. Samir, please have a look at it. I don't see there is something." I said, "Okay, I'll come." So this is the echo report they had already printed. No regional wall. These are standard copy paste, regardless of which
Yes, sir.
hospital you are in. No regional wall motion abnormality, ejection fraction 60%, normal cardiac chamber dimensions, normal color flow, normal mitral inflow, no intracardiac clot, vegetation, or pericardial effusion. Now, this is the thing which. So, anybody disagrees with this report, with this 2D? Nothing major.
Nothing,
I mean,
sir.
I would pass it off as normal. Okay, wonderful. And this is what she came and said that, Dr. Samir, I'm a little uncomfortable. What are this thing? Pass it off as normal, abnormal. Most of the people have
Normal.
said normal, normal.
Yes, sir.
Okay, lovely, lovely.
Grade 2.
So somebody give her a mic, please.
Grade 2.
This is the one you were trying to highlight. Agreed?
Sorry. Yeah.
This is the one? Well picked up. And what is this?
So I think it's systolic flow, and
Brilliant.
I mean that's very obvious. And I think it's in the same, low velocity, and it's the same direction as mitral inflow. So whatever it is, it's going in the same direction. HCM probably.
So HCM will have a flow in systole from above downwards.
Yeah. Depending on where the
Above downwards. Above downwards. I can debate it endlessly. It cannot. It is non-physiological. So systolic flow, what all are the valves which will have a flow in systole?
Aortic valve and pulmonary.
Aortic valve will have a flow in systole from above downwards. So
No,
it
it
cannot
does
be
not.
northwards.
Uh,
Sorry? Sorry?
Doppler, sir.
Wonderful. 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 So this is what it is. This is a continuous wave flow which will capture the velocity from top to bottom. Right from apex, she is correct. The mid cavity gradient will also show, but not from below upwards. Above downward. LV is contracting. When LV is contracting hypertrophic cardiomyopathy, it will push the blood downward towards the aorta. So physiologically speaking, it cannot come towards the apex. So this is what it is. Now, I said, listen, this is normal flow. This is pulmonary venous flow. And she says, how do you prove that it is not from somewhere else? I said, this is not from somewhere else. Put in a pulse Doppler. So we put in a pulse Doppler across the mitral. We didn't find any systolic flow. So we are clear that what we are picking up is from somewhere else. And this is continuous wave across mitral. If you look at this pulse wave, this has let the cat out of the bag that it is not from mitral or anywhere else. And this is a torrential pulmonary venous flow. Lovely. That sets the ball rolling. Anybody else who has got some cases? Otherwise, I'll have to pick up few more from somewhere. Okay. Tell me when to stop. Okay. So, 29 years old. Now, this may sound very racist, but I can't help it. If somebody is from Africa, he will be black. For the sake of the anti-racist movement, this is a gentleman from uh, Africa, presents with progressively worsening dyspnea and palpitation for 2 years. No history suggestive of rheumatic fever, no significant fast history. Diagnosed to have rheumatic heart disease with mitral regurgitation in Africa and is referred for surgery here. So this man has come for surgery. Eventually, he did get surgery. But let's see. Apical examination was the usual. Once you know if it is an MR, you will start picking up all the findings of MR. And this is what the echo is. Anybody who would want to comment?
Rheumatic heart disease only, sir. PML mobility is restricted.
Okay.
Hockey-stick appearance of AML.
So AML is showing some diastolic doming.
Yes,
okay.
Sir.
Severe MR, not severe MR.
Severe MR only, sir. LV is slightly dilated, sir.
LV is slightly dilated. LA?
LA is also dilated.
LA is also dilated?
Yes, sir.
Okay, lovely. Very good. Now talk about the LV.
LV contraction is good.
I'll come back onto this image again. Sorry?
Inferior septum is decreased.
Okay. So some bit of a dichotomy about wall motion abnormality, but he is 29 years old. Now, comment on the LV and LA. LV is fine?
LV is fine only, sir.
Okay. How often have you seen sigmoid septum in a 29 years old boy?
Sigmoid septum. Yes, sir. Not seen, sir.
Not seen. I have also not seen. Okay. LA?
LA is enlarged, sir.
Are you able to see LA properly?
No, sir.
Okay. And you are being, you don't want to be sounding insulting to me that Dr. Samir, you have not imaged the LA properly.
No, sir.
Okay.
Some tunnel is seen. Yeah.
He's got it. This one? Very sharp observation. This is what we were trying to capture. So he's got on to something which is here.
Yes.
This is something we had not been seeing. So this is very beautiful human principle. What the mind doesn't know, the eyes don't see.
Yes, sir.
So here we were all the time concentrating on MR and what it turned out to be. Look at this MR. It is there, but it is not gross. It is not severe florid MR.
Mild to moderate.
Okay. And this is something which is a flow inside whatever cavity he had showed. So this is almost a continuous flow which is going inside this cavity. Now comes the crux of the matter, that what the hell is it? Okay. Now you can say that it is going into aorta. You didn't show me the aorta well. First we'll talk about the MR. So this MR is nothing gross, and if you look at it, there are two separate jets going. One is into the MR and another is into that cavity which is having a predominant red flow. Red flow meaning some bit goes inside and most of it is coming out of it. So it is almost like a continuous flow. Okay. So this is what it is, comparison of the two. One is this cavity and another is MR. Both of them are separate from each other. And this is the cavity which was there in question. Now we'll have to find out what is this cavity and is there a truthful flow in it. So let me just show you the truthful flow in it. It does go inside there, which is separate from aorta. You can say you have not shown me the aorta yet. Why is it that it is not an aneurysmal aorta or there is a coarctation that it is preventing blood to flow in? So it doesn't look like it. I can give you some physiological reasons that it is not aorta, but all the same, let me just show you what it is in. This is the aorta. Convinced?
Okay, sir.
This is aorta. Anything else you want to see? And then we'll come to the diagnosis.
Do you have the short axis of aortic valve?
Short axis aortic valve. Okay. Okay. Let me just see. No. So there is. Wonderful. What is it called? It is a submitral aneurysm. So this is a subvalvular aneurysms. They can occur at subaortic level. They can occur at submitral level. This is exclusively seen on the left side of the heart. Actually, post-mortem, it has been described almost 2 centuries back. It is a rare illness. It is described predominantly and indigenously in African population. There is no specific gender predilection, and submitral aneurysms, they are related to posterior annulus of the mitral valve. Anteriorly, if they are occurring, they will be labeled as subaortic aneurysm. But if it is posteriorly, then they are selectively into the relationship of mitral valve. And the problem is that many a times the subaortic ones are the more difficult ones to handle because they involve the left coronaries or the left cusp, and then it is. So this is a congenital weakness of fibrous annulus in relation to PML, and rarely the circumflex can be, and management is eminently surgical. We have had some very many ways of doing it, but this boy underwent surgery and he survived well. But the largest series we have from Delhi is from the Army Hospital. They have done 4 cases of submitral aneurysms in last 10 years or so. Very encouraging results. 1 survived, 3 died. So these are very uncommon and can have varying modes of presentation. With increasing number of foreign nationals traveling all over the world, we need to be vigilant about this entity. Any discussions? I'll pick out some more cases.